A very good morning to all of you. I am Pranav Doshi. I am an intern at St. GS Medical College and KM Hospital. Today we will be starting with our very first session on history taking and examination in pediatrics. For your university examinations, you will be having a long case of 30 marks, a short case of 20 marks, OSCE for 40 marks, and Viva of 10 marks, which will compose of nutrition, X-rays, drugs, and instruments. Today, we will also be covering anthropometry assessment, which will come as a question in your OSCE. So this is the list of exam cases. You guys can take a screenshot right now. We will try our best to cover as many cases as possible in the next 1 month. Okay, so let us start off with history taking. The very first thing that comes is demographics. Usually in any history, be it medicine, surgery, or OBGYN, the usual pro forma for demographics will be name, age, gender, residence, occupation, and religion. Now, pediatrics has a slightly different pro forma. Instead of ROR, we will rather be having birth order, consanguinity, non-consanguineous marriage or consanguineous marriage, residence, and informant. So, how do we present this demographics? What you will say is, my patient, the name of your patient, is a 5-year-old boy or girl, dashed by birth order, born of a non-consanguineous marriage. If it is a consanguineous marriage, you also have to specify what is the degree of consanguinity. Residing at and hailing from. Informant is mother who is reliable. So, what is the significance of name in this demographics part? Name helps us to identify our patient and build rapport with the patient. Building rapport is more so in medicine and surgery cases, not much in pediatrics cases. The significance of age and gender will be dealt individually in each of the cases that we'll see at a later point of time. Then comes consanguinity. There is a higher risk of autosomal recessive diseases in consanguineous marriages. What are the degrees of consanguinity? A first degree consanguineous marriage would be between parents and children or between brothers and sisters. A second degree consanguineous marriage would be uncle, niece, or aunt, nephew. The most common one is the third degree consanguineous marriage, which is between first cousins. Secondly, what is the criteria to tell that the informant is reliable? A reliable informant could be one who is a blood relative, one who is staying with the child, a literate, or an adult. Next, what is the significance of mentioning the birth order? A higher birth order would indicate a high maternal age. One can also inquire about diseases in their siblings. And with a higher birth order, there is an increased risk of neglected child. All right. So that is about the demographics. The second and most important part of the history happens to be the chief complaints and the history of presenting illness. At this point of time, let us reflect what is the basic purpose of history taking and examination. The basic goal would be to arrive at a diagnosis. Your chief complaint and HOPI is a very essential part that will direct the examiner to ask you questions as well as helping you to arrive at a diagnosis. Let's say your chief complaint is breathlessness or pain in chest. The very first question that you can expect from your examiner is what are the differentials of breathlessness? What are the differentials of chest pain? Next up, what will you be covering in HOPI? So let's say your chief complaint is breathlessness. Now your HOPI has to be such that you will be able to rule out all the most of the differentials based on your negative history and narrow down your differentials to arrive at a probable diagnosis. Your examination will further aid you to arrive at a definitive diagnosis, but certain cases definitely will require investigations to confirm your diagnosis, and then your viva will go on to your treatment part. So, what will be the components of negative history? To simplify it, we can say negative history will be composed of three parts: negative history of associated symptoms, negative history of etiology, and negative history of complications. Now, what questions should be asked? What are the differentials for each of the chief complaints? All this we will cover individually in each of the cases that we'll see later. Right now, getting back onto the proforma, we will move on to the next topic, that is past history. So, how to remember the order in which we have to take our history? First comes past history, then comes antenatal history. After the pregnancy period, the child will be born. So, after antenatal history, we have birth history. Once the child is born, first thing we do is we'll give him vaccines. So, second, next part is immunization history. After we give the vaccines, the child will grow, the child will develop. Next comes developmental history. Then the child requires food to grow. Next comes nutritional history or dietary history. And last comes family and socioeconomic history. A easy mnemonic to remember this is BID NFS. So let us start with our past history. Unlike medicine and surgery cases, please do not mention that there is no history of diabetes and hypertension in a pediatrics case. What to mention in past history? Whether there is history of any similar illness in the past. More so relevant in cases of in cardiac cases. So in cardiovascular diseases, there are certain cases where we have recurrent respiratory tract infections. We will cover this again when we do CVS cases. History of any significant illness or surgery done in the past. It is very likely that a CVS case might have been operated earlier. So that comes here. Do mention about the common illnesses, whether there is any history of measles, TB, or TB contact. After past history, we come on to antenatal history. While presenting your case in exam, all you have to mention is antenatal history was uneventful. Even while taking your history, you ask only the relevant points to the patient. Do not just ask everything like you do in OBGYN. For antenatal history, so what we will do is when I cover OBGYN history taking, I'll explain this part. We'll keep the antenatal history same for OBGYN and pediatrics. This will help you to remember it better. Right now, just take a screenshot. I'll explain everything when I cover OBGYN. So this is for the first trimester. For ease of remembering, we divide it as investigation, drugs, and diseases. These are all the points that need to be covered. This is for second trimester, and this one is for third trimester. Okay. Next comes birth history. So in case of an old child, around greater than 5 years, all you have to mention is birth history is not contributory. For a child less than 5 years, you need to describe it as follows. So the mother had spontaneous or induced onset of labor. Which was at term, preterm, or postterm. She underwent a full-term normal delivery, or it could be a case of cesarean section or an instrumental delivery. Instrumental delivery is one where we use forceps or ventouse to deliver the baby. In these cases, you need to mention the indication for which a cesarean or instrumental delivery was done. So you add this was done in view of whatever be the indication. Next, she delivered a male baby weighing 3 kilograms. And the baby cried immediately after birth. Next, we talk about breastfeeding. So she breastfed the child dash hours after birth. In cases of a full-term normal delivery, it would be within half an hour, and in cases of cesarean, it would be within 6 hours of delivery. And exclusive breastfeeding was continued for 6 months. Next, you mentioned whether there was any NICU stay. If there was, then what was the indication? How much duration? Whether there was any history of any other significant illness during the neonatal period. What are the significant illness that I'm talking about here? So, example, neonatal jaundice, seizures. If it is a case of jaundice, do inquire about the day of onset of jaundice, whether it was from day one So if you have read about jaundice, you will know that pathological jaundice appears from day one, whereas physiological jaundice does not appear in the initial 24 hours of life. And what was the treatment given, whether it was phototherapy, whether any exchange blood transfusion was done. So this part is also covered in OBGY, but for pediatrics and birth history, the focus of examiner will mainly be on this part. So try to expand as much as relevant in this part. Any illness that the child had to face. That is about birth history. Next, we move on to immunization history. So a simple technique is go to the mother and just ask for that NIS card. We'll go through it, or you can ask the mother whether all vaccines have been taken till date. If yes, just mention that child is immunized till date. Also, it is important to mention when was the last immunization. So last immunization received, let's say, at 9 months of age. Or it could be a case where the child is not vaccinated. Inquire specifically which all vaccines not taken. You don't need to have each and every vaccine written in your sheet with exact date. This much is sufficient for immunization history. Next comes developmental history. So in case of an old child, which is greater than 5 years, all you have to mention is that all milestones were achieved at the right time. Also mention about the scholastic performance. Tell that he is good at studies and he makes friends at school. One thing that all your teachers will tell you again and again is that history has to be in patient's wordings. Keep that in mind. Then comes a child who is less than 5 years. So in this case, you have to mention two recent milestones that he has achieved in each and every domain: gross motor, fine motor, social, and verbal. So let's say you will say social smile is achieved at 2 months or head control achieved at 3 months. Gross motor, fine motor, social, and language. Two milestones, the most recent ones in all. That is enough in a normal case. If it is a case of CNS, especially if it is a case of developmental delay, then you have to take the history in detail, ask about each and every milestone. Then comes the question, what is a development quotient? So the formula for development quotient is a developmental age divided by chronological age into 100. So let me give you a small example for this. Let's see a child is 2 years old, age being 2 years, but based on his developmental tests, he functions at a development age of 18 months. So what would be the DQ in this case? So DQ has to be calculated with numerator and denominator in months. So 18 by 24 into 100. That comes out to be 75 percentage. DQ in this case is 75. We'll have to calculate development quotient in each and every domain separately, as well as an average of the average of all four. We say that there are delayed milestones if the DQ is less than 70%. Another important point, what if your child is preterm? So let's say that your child was born 2 months uh, before term, and right now his age is 5 months. So rather than the actual chronological age of 5 months, we will be using the corrected age. So the corrected age will be 5 months minus 2 months, corrected age being 3 months. So this correction has to be used up till 2 years. After that, this correction doesn't have to be followed. Basically, when your child is 2 months preterm and his corrected age is 3 months, expect him to have all the developmental milestones which a normal term baby will have at 3 months. Okay. A developmental age, when I say that the developmental age is 3 months, it means that the child is able to do what a 3 month old can normally do. Next, we can move on to the nutritional history. We have completed developmental history. Okay. So, nutritional history for a child who is less than 2 years. This is a sample case presentation. You can modify it according to your case. What all points are to be covered? First of all, talk about exclusive breastfeeding till what age? Now, you would be on complementary feeds. For example, rice kanji, half water, thrice daily, maybe biscuits, maybe one mati dal. Also read about what are the common weaning foods that are used. Mention about the frequency and whether night feeds are given. Mention if any top feeds are given, what is the reason for initiation of top feeds, whether milk is given by bottle feed or vati chamach, and whether this is clean or not. In case of a child greater than 2 years, first of all, mention that exclusive breastfeeding was given for 6 months, and then complementary feeds were started. This is a sample dietary history, which is taken by 24-hour recall method. You can take a screenshot. So while presenting nutritional history, it has to be presented in a certain way. So you have to make a chart in your sheet as calorie, protein, observed values, expected values, and the deficit has to be calculated. So how do we calculate the observed values? I'm very sure that this has been covered in PSM. I'll just brush up through it. So you will first of all take your 24-hour dietary history. Some of the common values that you can remember and which will help you in exam are a fulka roti will have approximately 80 kilocalories and 2 gram proteins. See, again, these values are not exact. They have been rounded off for the ease of remembering. But even if you remember just this for your exam, it will work fine. Most of the times, the examiner may skip this part, but this part becomes especially important when you have a case of severe acute malnutrition, where this history will be focused upon by the examiner. One katori vegetable cooked will have 80 kilocalories and 2 gram protein. 1 cup of rice will have 170 kilocalories, 4 gram protein. 100 ml of cow milk will have 65 kilocalories and 3.3 gram protein, whereas human milk 100 ml will have 67 kilocalorie and 1.1 gram protein. So using this, you can have a rough estimate of the observed calorie and protein intake. Now, how do we know what is the expected value? So, in case of an infant who is less than 1 year of age, calorie will be 100 kilocalorie per kg per day. This is the expected value. And proteins in units of gram per kg body weight of the child per day would be 2, 1.5, 1.4, 1.3. So this is up till 1 year. 2 grams per kg per day is up till 6 months. 1.5 is up till 3 years. 1.4 is up till 6 years. 1.3 till 9 years. So up to 6 months, the protein requirement is 2 gram per kg per day. From 6 months to 3 years, it is 1.5 gram per kg per day. From 3 to 6 years, 1.4. And from 6 to 9 years, 1.3. What about a child greater than 1 year up till 12 years? So we will be using the holiday cigar formula to calculate the calorie and fluid intake. So calorie in terms of kilocalorie per kg per day and water requirements in units of ml per kg per day. For the initial 10 kgs, for the next 10 kgs, and after that, it is 100, 50, and 20. Same values over here. So for example, suppose your child weighs 16 kgs and he is 2 years old. You have to calculate the calorie requirement, the expected calorie requirement. Also, one point to note here is when I say 16 kgs, it is not the observed weight, it is rather the expected weight that we have calculated from the growth chart. So at 16 kgs, for the first 10 kgs, multiply by 100. For the next 6 kgs, multiply by 50. And it comes out to be 1300 kilocalorie per day. Okay. So that will be your expected. Subtract it and you will get your deficit. Okay. Then comes what if your child is breastfeeding? Okay. So my suggestion is do not say upfront the calories observed or expected values in cases of a breastfed child. You must have it written in your sheet. Only if the examiner points out, then mention about it. Okay. So roughly at 4 to 5 months, the milk requirement for an infant is 600 ml per day. At 6 months, it is 750 ml per day. After 6 months, what you can do is just ask the mother how much is the milk output. So she will be able to tell you that whether it is 100 ml, 200 ml, and based on the values that we have written here, you can calculate what is the observed calorie and protein intake. Keep all this calculation to the very end because most of the times the examiner will skip this part. Rather, first focus on completing your examination, completing your summary and diagnosis, and then come back and do all these calculations. Another question that the examiner may ask you is, how do we know whether breastfeeding is adequate or not? So, adequacy of breastfeeding is indicated by if the baby passes urine 5 to 6 times a day, if the baby sleeps well after each breastfeed, and if there is good weight gain, it means that the breastfeeding is adequate. Okay, so we have completed nutritional history over here. Next comes family history. Before family history, there's a point about personal history. You have to skip this part if it is a small child. In case of an old child, you can just simply mention that bowel, bladder, sleep, and appetite are unaltered, and there are no known drug allergies. Do not mention about addictions or something like that. So, bowel, bladder, sleep, appetite, unaltered. Better to use the word unaltered rather than normal. No known drug allergies. It is okay if you skip this part entirely in a pediatrics case. No hard and fast rule to include this. Then comes family history. So what all to mention here? If there is any history of similar illness in family, more so important in cases of communicable diseases, for example, measles. Maybe there's a history in a sibling also. Then it is essential to make a two-generation pedigree chart and show consanguinity in your chart. This has to be made in your sheet. Do not say it upfront. If the examiner asks you to show, then only show it. So let's say uh, mother is 22 years, father is 25 years, and they have a child, 3 years, and this is your case. Uh, in cases of a genetic disorder, then you have to make a three-generation pedigree chart. Next, we can move on to socioeconomic history. Again, this is less important, so complete it at the end. This is a sample socioeconomic history. What you can do is, just in case you don't have enough time to take this history, just simply write the same one. Uh, I don't think the examiner will catch you on this. He won't go and ask the patient whether these details are correct or not. And in any case, you would have studied it in TSM, so you should be able to answer if any questions are asked. So family belongs to which socioeconomic class using the modified Kuppuswamy scale. Family lives in a pakka house. How many rooms? Shared by how many family members? The sanitation is good. Regular water supply. Father's occupation. Studied till what age? Till which standard? Earns how much? Mother is a homemaker. Studied till 10th. And if he has a younger sibling of dash age and who is doing well at present. So that is about your socioeconomic history. With that, we cover the history taking part. Now we will be moving forward on to the examination part. At the end of the history, be ready with the summary. The examiner might just skip on to the summary. So be ready with that part. I will mention what all has to be included in your summary at the end. So going on with examination right now. First of all comes general examination. It is very important, especially for our CBAB match, to mention about consent. Even if the examiner says you that just skip on directly to local examination, first line has to be that the patient was examined with consent. This is very important. So first of all, mention patient was examined in adequate light and exposure with due consent. Normally, in a medicine or pediatrics case, we would mention that the patient is conscious and cooperative. In case of a child, mention that the child is alert, active, and playful. Of course, in an older child, you can say the child is conscious and cooperative. Or your child may be lethargic, irritable, or drowsy. In case of kwashiorkor, the child can be described as being apathetic, and in marasmus, you can say that the child is alert. Then comes vitals. So it is important to remember the normal values. See, again, these values are not exact and precise, but they have been rounded off and will help you to better remember these values. So you can prepare these and say these in your exams. More so, sometimes we get a 20-minute time frame during our university practicals to take the case. It is possible that you might not get enough time to take the BP or to take all the vitals. In those cases, you may just make up findings, normal findings, but be smart enough. In case it is a serious case, definitely you have to take the BP and heart rate, etc. So the normal temperature range is 97.7 to 99.5 degrees Fahrenheit. The newborn heart rate is 110 to 160. 1 to 4 years, 110. Next 4 years, 100. Next 4 years, 80 to 90. Respiratory rate would be 40 to 50 in a newborn, 30 to 40 from 1 month to 1 year. 4 to 6 years, it would be 25 per minute, and greater than 12 years, it would be 18. Then comes blood pressure. In a newborn, the blood pressure would be 75-45 mmHg. Then every year, you add 3 mm in systolic and 2 mm in diastolic to get the normal blood pressure value until you reach 120 by 80 mmHg at 12 years of age. So this is another way that you can find out the normal BP. And just in case you don't get time to measure the actual BP, you can write this. Then you have to mention about capillary refill time. The normal value is less than 3 seconds. So in an infant, capillary refill time has to be checked either on the sternum or the heel. How do you check it on the heel? So you lift the leg of the patient, press on the heel for 5 seconds, then release it and calculate the time required for refilling. We calculate each second as 1001, 1002, 1003. And if it is less than 3 seconds, it indicates that capillary refill time is normal. It can be less in cases of, it can be increased in cases of shock or vascular insufficiency. Next, you mentioned that peripheral pulses were well fed. Okay, so that is about vitals. And for temperature, in young children, oral temperature should not be measured. We use either axilla, rectal, or groin temperature. In protein energy malnutrition cases, rectal temperature is to be taken. In cases of hypothermia, the rectal temperature would be less than 35.5 degrees Celsius. And axillary temperature would be less than 35 degrees Celsius. If the rectal temperature is less than 32, it indicates severe hypothermia. And the time for which the thermometer has to be placed is 3 minutes at any side. I would recommend you all to take your own thermometer. It's possible that the examiners might not provide you a thermometer in the exam. So, second point was vitals. Third point is pickle, whether there is any pallor icterus, cyanosis, clubbing, lymphadenopathy, or edema. Next comes anthropometry, something that you do only in pediatrics, not in other subjects. Again, you need to make a table for this, the observed values, the expected values, and the percentile. So what all are we supposed to measure? First of all, weight, height, head circumference, mid upper arm circumference, chest circumference, upper segment to lower segment ratio, and abdominal circumference. Now, instead of height, up till 2 years of age, you measure the length. Head circumference has to be measured only till 5 years of age. Mid upper arm circumference only in a child more than 6 months and up till 5 years of age. Chest circumference only till 3 years of age. Upper segment to lower segment ratio you have to do only in cases of long or short stature. It is unlikely that you will get this case in your exams, but still, if you do get, and if it is a case of long or short stature, then you have to measure US to LS ratio. Abdominal circumference has to be done only in cases of ascites, otherwise, do not mention it. To summarize, if your child is greater than 5 years, measure only height, weight, BMI. Next, you have to plot these values on a growth chart. So you will plot for weight, weight for height, weight for age, weight for height, height for age, head circumference. For MUAC, you do not have separate growth charts. I will mention the expected values in a minute. Growth charts will be available for these. It would be available for BMI also. So for these, you will plot the expected value, the observed values on the growth chart. You will find the expected values from the growth chart itself. And when you present your findings, you don't have to read out the whole table. You have to present it as weight is dash kgs, expected being dash kg, and the observed value falls between -2 standard deviation to -3 standard deviation, and then mention what is your impression, whether the child is undernourished, whether he is severely stunted, whether he is wasted, whether it is a SAM child. If head circumference is less than whether it is microcephaly, this has to be mentioned. All right. One of the questions that the examiner may ask you that which growth charts are to be used. So in cases of child less than 5 years, we use WHO growth charts. Greater than 5 years, we use Indian Academy of Pediatrics growth charts. Also mentioned that separate charts are available for Downs and preterm. But in case during your exam you get a Down syndrome case and you do not have a Down syndrome specific growth chart, then in that case you can continue with the normal growth chart. For mid upper arm circumference, less than 11.5 centimeter implies SAM, severe acute malnutrition. 11.5 to 12.5 centimeter implies moderate acute malnutrition, and greater than 12.5 centimeter is normal. Okay. So we have covered the anthropometry part, what all has to be asked. Next, during your Viva or especially during your OSCE, there are certain questions that you will be asked, a bit fact-based, but we will try to remember it easily. So write it with me: weight, height, and head circumference at birth, 6 months, 1 year, 2 year, 3 year, 4 year. So the normal birth weight would be 3 kg. Then just follow the table of 3, 3, 6, 9, 12, 15. Separately remember 16 kgs at 4 years of age. Height, so 50 centimeter. At 1 year, it is 75 centimeter. And at 4 years, it is 100 centimeters. 6 months, 65. 2 years, 90. And 3 years, 95 centimeters. All right. Head circumference, 34, 43. 2 years, 3 years, and 4 years, 48, 49, and 50 centimeters. And at 1 year, 46 centimeters. So there is an underlying pattern which can help you to remember it a bit more easily. And these questions are asked in exams, so you need to remember this. Another very favorite question is US to LS ratio. Yeah. So upper segment to lower segment ratio is 1.7 is to 1 at birth, 1.5 is to 1 at 1 year, 1.3 is to 1 at 3 years, and 1 is to 1 at 10 years. All right. As for chest circumference, all that you need to remember is in less than 1 year child, chest circumference is less than the head circumference. At 1 year, chest circumference will be equal to head circumference, and greater than 1 year, chest circumference will be greater than head circumference. This is lesser than head circumference by 3 centimeters. Okay. So that is done. Also, they often ask at what age the weight doubles, at what age the weight will triple. So the weight doubles, the birth weight will double at 6 months. It will triple at 1 year of age. It will quadruple at 2 years of age, and it would be 10 times at 10 years of age. So that also you have to remember. Next, we will discuss what are the formulas to predict adult height. So one of the formulas is mid-parental height formula, where you will add the father's height and the mother's height plus minus 6.5 and divide it by 2. So you will add 6.5 if it is a male child. You will subtract 6.5 if it is a female child. Another formula is called as Tanner's formula, which is basically you double the height at 2 years of age, and that will give you the adult height. Less than 2 years, we do not measure the height, we measure the length using an infantometer. And greater than 2 years, we measure the height using a stadiometer. One of the questions that was asked to me in my OSCE, in my university examination, was to demonstrate the measurement of a head circumference and what is the progression of head circumference with age. So the method is you place the tape from the external occipital protuberance to the superior orbital ridges by cross tape method, and then you find the head circumference. Now, what is the progression of head circumference? Again, write it with me. 2 centimeter per month, 1 centimeter per month, 0.5 centimeter per month, 2 centimeter total, 1 centimeter total, and 0.5 centimeter total. This is up till 3 months. This is from 3 months to 6 months. This is 6 months to 1 year. This is 1 to 2 years, 2 to 3 years, and 3 to 4 years. Again, there is an underlying pattern which will help you to remember it easier. Chest circumference again has to be measured by cross-check method. Only up till a child of 3 years at the level of nipples and midway between inspiration and expiration. I mentioned that US-LS ratio has to be done only in relevant cases. The upper segment would be vertex to pubic symphysis, and pubic symphysis to heel would be the lower segment. One favorite question would be, in what cases will US-LS ratio increase? So this ratio would increase if the trunk is more longer or the lower limbs are shorter. So in what cases will lower limbs be shorter than normal? So cases such as achondroplasia, or in cases of bowed legs seen in a condition called as rickets, or conditions having limb deformities, we can have a US-LS ratio greater than normal. What cases will US-LS ratio be lesser than normal? Either the trunk has to be shorter or the lower limbs have to be longer. So diseases where we see increased length of lower limbs are Marfan syndrome or Klinefelter syndrome, and conditions having a lesser length of trunk would be conditions like spinal deformities such as scoliosis. Usually you are not asked to measure the arm span, but you should know the method. So in cases of long or short stature, you will ask the patient to horizontally outstretch his or her arms, then place the tape from the middle of the tip of the middle finger of one hand, pass the tape around the back of the child, and measure up till tip of the other middle finger. It would be abnormal as an a reduced arm span would be seen in short limb dwarfism, and an increased arm span would be seen in Marfan's or Klinefelter syndrome. Okay, I think we have covered everything that is required for anthropometry. Mm. So next comes head to toe examination. Again, you guys can take a screenshot of this slide. What you have to say during your exam is head to toe examination is normal. If any abnormalities, say it at first. BCG scar mark is seen or not seen. Also, you have to mention about stigmata of TB or infective endocarditis. I will explain this in relevant cases. You don't have to say it in each and every case. Now, if the examiner tells you that describe your head to toe examination findings, you will say head is normal in size and shape. Anterior fontanelle measures A by B centimeters. So suppose this is your anterior fontanelle. You measure this distance, let's say A is coming out to be 1 centimeter, and measure B This comes out to be 1 centimeter. So tell it that anterior fontanelle measures 1 by 1 centimeter. Posterior fontanelle was closed as per your findings. What is the normal age at which the anterior fontanelle closes? So it closes around 18 months of age, and the posterior fontanelle closes around 6 to 8 weeks. Then hair is normal in color and texture. There are no signs of vitamin deficiency in the eyes, no icterus or xerosis, no ear discharge, no chlosis or glossitis in the mouth, no lymphadenopathy in the neck, no visible neck veins. In the trunk and abdomen, there were no visible veins or mass, no pedal edema, spine and genitalia were normal, and there were no obvious congenital anomalies. That is about your head to toe examination. Now, let us discuss some of the abnormalities that you can expect in your head to toe examination. First of all, beginning with the shape of the skull. A skull with reduced AP diameter will be called as brachycephaly, whereas a skull with increased AP diameter will be called as dolichocephaly. Brachycephaly occurs due to premature closure of the coronal suture, whereas dolichocephaly occurs due to premature closure of the sagittal suture. You may have a prominent occiput in cases of Dandy Walker syndrome. Dysmorphic features may be seen in Down syndrome. Down syndrome is a very favorite LAQ, SAQ, or a Viva topic, even in your theory and even in your practicals. So read all the features seen in Down syndrome very well. What are the conditions where there would be delayed closure of fontanelles? As we saw that the anterior fontanelle closes by 18 months and posterior closes by 3 months, by 6 to 8 weeks. So what are the conditions where there would be delayed closure? So it is seen in hydrocephalus, rickets, Down syndrome, and hypothyroidism. What are the conditions where you see a bulging fontanelle? It would be seen in cases with increased intracranial pressure, a depressed fontanelle seen in cases of dehydration. Is that easy to remember? Quite logical enough to remember, actually. Then, in OSCEs, they can ask you certain unique signs seen in the skull, such as the Max-Even sign. So, Mac-Even sign, what you do is you focus from one side of the skull and you place the stethoscope on the other side. And if an amplified sound is heard, it indicates a positive Mac-Even sign. So, this could be either due to raised intracranial tension, or it could be due to physiologically, it could be present if the anterior fontanelle is still open. Then you all know what is craniotapes. It is the first sign in infantile rickets. Another question which was asked in our prelims was when is trans elimination test positive and what is the cutoff value? So it is positive in hydrocephalus. And I think the question was when is it significant? So if it is greater than 1 inch in frontal area or it is greater than half inch in occipital area, then the trans elimination is considered as significant. What are certain abnormalities that you can expect in the eyes during head-to-toe examination. So you may see Kaiser-Fleischer rings seen classically in Wilson disease. You can see white rod spots in vitamin A deficiency, or you may see a congenital cataract. What are the abnormalities you can expect in the ear? The child may have a low set ear seen in Down syndrome. So when do you call it as low set ears? So where you draw a horizontal line from the palpebral fissure, if whole of the auricle lies below it, then you call it as low set ears. Other deformities may be in the form of microtia, skin tags, or pre-auricular sinus. Then what will you seek for in the mouth? You may see vitamin deficiency ulcers, left lip or left palate, oblique spots, again a very favorite LAQ in theory, seen in measles. A fact about dentition may be asked, when is the first deciduous, which is the first deciduous teeth to erupt? So it is a lower central incisor, the first deciduous teeth to erupt at 6 months of age, and the lower first molar is the first permanent teeth to erupt at 6 years of age. Next, what are the abnormalities that you can expect in the tongue? So a beefy red tongue may be seen in cases of B12 deficiency, and a strawberry tongue, a very famous MCQ seen in Kawasaki disease. Then comes neck. There may be swelling in the neck and diseases like diphtheria and mumps, or web neck may be seen in Turner syndrome. Visible veins seen in heart failure, or enlarged lymph nodes may be seen. BC Carmack has to be mentioned in all the cases. In 10% of the immunized cases, the mark is not seen. Hence, absence of mark does not necessarily mean the missed vaccination, nor does it mean that there is a need for re-immunization. Other findings that you can find in the skin. Okay, so you have to check for turgor to assess for dehydration. The best site to check it is the anterior abdominal wall. You may see a rash indicative of any exanthematous illness. Next, you may see some subcutaneous nodules, as in cases of rheumatic fever. Now, what are neurocutaneous markers? See, the skin as well as the nervous system both develop from the ectoderm. So, any developmental defect in the ectoderm will cause a manifestation in the nervous system as well as in the skin. These markers are associated with certain neurological diseases, so such as cafe or lay spots seen in neurofibromatosis. We have Ashley's macules, tubers, and shagreen patches. in tuberous sclerosis. Then we have capillary hemangioma, seen in Sturge syndrome. There's a long list given in Arut Shami, but I think these many should be enough. Uh, Tuft of hair on the back may be seen in spina bifida. All right. Then abnormalities that we may expect in the nails, latonychia and koilonychia seen in iron deficiency anemia. Some of the abnormalities that we may see in the hair, flax sign seen in routine energy malnutrition, kwashiorkor. Some of the deformities seen in bones, joints, or spine include kyphoscoliosis, seen in cases of rickets, or you may also see it in cases of neural tube defects. We have mentioned that genitalia are normal. You can expect your viva to go on sexual maturity rating, Tanner staging. Uh, what are the congenital anomalies that we can expect in cases of in the genitalia? So something like epispadias or hypospadias can be seen, right? So these are some of the abnormalities that you are seeking for during your head-to-toe examination. Okay. After all this 5 points comes your systemic examination. Now, each of the systemic examination will be taught in detail with their respective cases. As of now, I'm just mentioning what point you have to mention. Suppose you have got a CVS case, you have performed your CVS examination in detail. After telling all about your CVS examination, what else do you have to mention? So in GIT, all you have to mention is abdomen is soft, non-tender, no organomegaly. RS, bilateral equal air entry, and no adventitious sounds heard. CNS. Now, in case of a young child, just mention that cry tone and appearance are normal. In case if the child is old enough, mention that power, tone, and reflexes were normal. And if it is a RS case, then the other three systems would be GIT, CNS, and CVS. So just mention S1, S2 heard, no murmurs. Okay, just say S1, S2 normal, no murmurs. Next, most important part that the teacher may ask you is the summary. What all things have to be included in the summary are name, age, gender, chief complaints, all the positive points in your history and examination. And you can, if you have got a probable diagnosis, you will say probably a case of, or else you can just give your differentials. Last will be your diagnosis. Three parts: name, etiology, complication. You'll understand how to tell the diagnosis as in how we practice in the subsequent sessions. Along with this, you also have to add about whether it is a SAM child, ma'am, or by history examination, if you have got to know if there is any developmental delay. Okay, so that is about the basic pro forma that you have to follow for your pediatrics history rating. Okay, thank you very much for your patient listening. Uh, Another important thing, each and every text that I have told you in this lecture or in the subsequent lectures has been taken from these books or these sources, and I have tried my level best that each and every word is factually correct. Still, if you find that there are some discrepancies, do let me know in the chat section. You can contact me on WhatsApp, Instagram, or YouTube. You can ask any of your doubts in the comment section below. And thank you very much. Goodbye.